This session is being recorded, and we will be posting the recording on our website for those that would like to access it in the future. Joining us for today's panel, we have Dr. Jonathan Green, who is a clinical psychologist and senior advisor at O'Connor Professional Group. He consults for tech startups focusing on measurement-based care and telemedicine, as well as for national insurance providers, and is also maintaining a private therapy practice in downtown Boston. Dr. Green's work on safety planning for suicide has been funded by the Department of Veterans Affairs, and his research has received awards from the American Psychological Association and the Association for Behavioral and Cognitive Therapies. He also has received awards from the Anxiety and Depression Association of America and the Military Suicide Research Consortium. Dr. Green is a founding member of the Suicide and Self-Injury Special Interest Group of the Association for Behavioral and Cognitive Therapies, and he is the president of the Men's Mental and Physical Health Special Interest Group. Today, we are also joined by Margaret Stone, who is an executive coach and professional case manager with O'Connor Professional Group. She's also the founder of the Veterans Healing Initiative, a national nonprofit that advocates for substance abuse and trauma treatment for veterans. In September of 2018, Margaret and her husband lost their 21-year-old son to suicide. She's now a passionate advocate for suicide prevention and volunteers as a support to families who've lost a loved one to suicide. We are also joined by Diana Clark, who is O'Connor Professional Group's Chief of Clinical Operations. Diana is a renowned family recovery advocate in the field of mental health and addiction treatment. She is also the daughter of a parent with diagnosed bipolar disorder who attempted suicide 20 years ago and expressed suicidal intentions just 3 months ago. I'm very grateful for all of our panelists, especially Margaret and Diana, who have so generously offered to share their personal experiences and shine a light on this very important subject. At the end of the conversation, we will leave time for questions. You can put your questions into the chat box. Please note that if you would like to ask an anonymous question, chat your questions to all panelists instead of to everyone, and it will be asked anonymously. Thank you again for your participation, and please enjoy the panel.
Thank you so much, Whitney, for the warm introduction to everyone, and I'm glad to be with you all today, and certainly with the other folks on this panel. Great that we're able to have a conversation that will balance, what's known broadly in the clinical literature about suicide, including the most recent advances to that end, and also to have a better understanding, hopefully by the end of our discussion today, of what practical advice can be offered to families, not just from what the data and the science have to say, but also the lived experiences of folks who have understood this phenomenon from so many different angles and bring with it sort of the state-of-the-art understanding of what can be done. I wanted to open the talk today first by making sure that we're all up to date in the way that we talk about suicide. There's, as is the case with many challenges that show up in mental health, there's a lot of old language that we're plagued by and that we're left with. And it does us a disservice to use it because we don't really understand what people are going through when we use it. And it does the people who are struggling a disservice to use it because it doesn't capture their experience. It actually makes us more distant from them. And what we know more than anything else when it comes to suicide and the suffering people have, connection is one of the most important things we can do. And so we don't want our language to get in the way. So to that end, some of the kind of common language that you'll still see float around suicide in particular is this notion that someone commits suicide. You'll see that language still show up. Certainly an old term. Commit is really more of a legal term. Back when we used to think about suicide as being something that someone would do that was a crime, when it was a crime to commit suicide. Far more empathic these days to think about somebody dying by suicide, I think, is the best way to think about it, because that's more accurately what happens. I'd say sometimes I'll still hear professionals use a term like that someone suicided. It's not technically incorrect, but it hits the ear kind of hard, and I don't feel like it's the best way to discuss that with patients or with families. And then the other that seems really important for us to be aware of is this term that's thrown around, suicidality, broadly. And it's a big term that doesn't really help us understand the specifics of what's going on for someone. There's a wide range between somebody who will think about dying by suicide, who will just have thoughts, maybe I just don't want to be here anymore. I just don't want to deal with this anymore. If we look at numbers from the CDC, for example, that's about 4% of the US population in a given year will report and say, I have some sort of thought about not being here anymore. And I think that number is actually quite low. But that's different than somebody who goes ahead and develops a plan and says, here's a way that I'm going to go about dying by suicide. CDC says that's about 1%, probably also a little low. And beyond that, we have people who will actually attempt suicide, who will get to a point where they will engage some means and start to put forth effort to die. It's about 0.5% of people in the US by the CDC. But using one term to cover all this doesn't help us understand what the person we're ultimately trying to relate to is going through. We want to try and use language that's very specific and helps us understand what they're dealing with. I'll say too, in terms of the quality of the research more broadly and what's going on in the field, there have been a lot of efforts to try and understand who's thinking about suicide, who might have this on their mind. That alone isn't actually all that helpful to us because, again, if we think about the numbers in a given year, at least in the United States, of those who think about dying by suicide, even who have had the thought, less than a fraction of a percent of those people will actually die by suicide. So being able to understand and predict what's going on in someone's head, or sort of predict suicide as a set of thoughts, not all that helpful. So if we're either families that are interested in this, or we're clinicians that are trying to understand it, reading research that's predicting who's thinking about suicide is not helpful. We need to try and look at better factors that are more helpful to that end. Those are the two terms that I see show up most often as challenging, but I also wanted to open it up to the panel. Are there other ways you've heard people talk about suicide that has not been helpful, that has not been useful, and seems to be things that, to the degree we have a platform today, can help to clarify that?
I think, in my experience, it isn't that people use the wrong terminology so much when they're talking about suicide. They just don't talk about it. So family members are left with this huge gaping secret between even people they're close with, because the word doesn't get used. And I think that's probably, in my experience, I would pass that to Margaret if she, her experience with the language as well.
I agree, Diana. I think that it's not talked about. And so there is this super secrecy to even using the word. The word itself is, just surrounded by condemnation. A lot of people will say, oh, well, they got suicidal ideation, or, they use suicide in a term as if it defines the person rather than it is a condition. It is a illness and an action. And if we don't talk about it, it makes the word even more negative. So I think to your point, Jonathan, you're right. I mean, committing, one of the things we were told in group was it denotes a crime. It's not a crime.
Right, exactly.
It's an event.
Right. And more than anything, I think what we can all say from our experiences, clinical and otherwise, the biggest challenge is that families don't discuss what's going on. And I'd say in the absence of having perfect language, I think we've all seen is that it's beneficial for people to talk about this at all with their imperfect language. But more than anything, it's something we need to step into and be aware of. Folks are having these thoughts and are having these feelings. And to the degree we don't broach the subject and don't open it up for discussion, we're really doing a disservice to those people who may be struggling and just not describing what's going on. Mm-hmm. I wanted to highlight briefly sort of what the state of the science is around how well we can figure out who's at greatest risk. We I think as providers and as families will often hear about risk factors. These things generally we need to be looking out for and try to understand, well, if my loved one is experiencing these things, then I will know that it's time to intervene or say something or do something. And I'll try to say it briefly because I think there's a lot of great work being done, and I think it comes to a pretty disappointing conclusion. So for the longest time, we've been told there are these lists of risk factors for folks who are not doing well. Maybe they're depressed. Often we think of depression coinciding with suicide. We think about people who are using substances. We've heard about people who have experienced traumas in the past. There's all sorts of demographic data that's helpful to understand. Women are more likely to attempt suicide. Men are more likely to die by suicide. The problem with a lot of the research as a whole, it looks back over a long window of time, right? I'll have a participant come in, I'll try to understand some of these things about them, and I'll have them come back or check in with them months later or often years later. And between those two time points, some of the folks in the research have died by suicide. And then I try to extrapolate, well, what was it about them that led them to die by suicide? The problem is the data tell us that really there's a narrow window of time where somebody goes from struggling and not doing well to moving very close to dying by suicide or making a suicide attempt. And if research has largely been looking over the course of months and years, we're going to miss that narrow window. We're not going to understand what it is that changed for that person in that short period of time. And so we do have this idea that folks, when they are close to dying by suicide, there is this narrow window of time, 24 to 48 hours, where they're having this acute suicidal affective disturbance, ASAD. Some great work done by a gentleman by the name of Raymond Tucker that's doing that work. And maybe if we can try to understand what are the changes going on in this person, we can understand a little better how to help them. There's also been a lot of great research that's tried to understand there are chronic factors. We know there are people that are out there in the world that have a difficult trauma history and have a history of self-harm and have all these other phenomena going on, but who are today quite stable. And yet there are other folks who don't have those histories, but they have a recent crisis that's going on and it puts them at risk. This idea of chronic risk factors versus acute ones. Things generally that set me up that I might struggle with, but really how am I doing today? And it's the today ones that we need to pay attention to. We can't get distracted by these big picture chronic ones. And so with a lot of those things together and some of the advances in data science, we have large hospital systems like the VA that have these big machine learning tasks that are going through thousands and thousands of medical records, gathering little bits of data moment to moment to figure out who's at the highest risk, who are the people that are most likely to die. The problem with suicide is that because it is such a low base rate behavior and it's so hard to figure out. There's one researcher at Harvard, Matt Nock, who's a fantastic suicide researcher who says we've narrowed it from trying to find needles in a haystack to now we're trying to find one needle in a stack of needles. And as great as that is, as much as we've done, I think the short version is the state of the science. And you can look back, there have been a number of great articles written about how much have we understood about suicide in the last 100 years. The understanding is that the science has done virtually nothing to reduce the number of people that die by suicide. Our ability to detect who's likely to die is quite low. And I remember we all, when we were talking about this, as we were planning for this panel, to some degree, none of us were surprised and all understood that that's probably not where we're going to make the greatest headway. Really, what we all have seen in clinical practice, and certainly personally as well, is that we need to focus on figuring out how do we intervene? How do we help people that are struggling, and how do we highlight that early on? Because we're probably not going to be developing a blood test for suicide anytime soon. We're not going to know one way or the other concretely. So with that said, the only other piece I'll add is, when we think about interventions and what's helpful, certainly there's been some data to develop ketamine as a kind of treatment, to develop means restriction. So even, I know we talked about blister packing medication so that they're not available in one large bottle, but are in little individual servings, can actually decrease the likelihood someone will die by suicide. And the use of safety plans, right? Finding ways to connect with folks, finding ways to look for professionals. But I guess one of the things that we all talked about and that we think is so important that we discuss as a panel is this idea that if the research is not sort of riding up over the hill like the cavalry anytime soon to offer us a fantastic new skill or set of skills or a great suicide detector machine, what can families do now with loved ones that they think may be struggling? How can they start to address any sort of these issues that are going on? And so Diana, I know you mentioned briefly, it's having the conversation to but I guess they stand and do something
Right.
today.
And I do think that it doesn't have to be dependent on how they're doing in that moment, as you said. So to start the conversation early, and I know it seems like a grim subject to raise. Do you ever think about taking your life? Or if you ever think about taking your life, would you talk to me about it? Just getting that conversation in that moment long before it becomes acute, I think, because then you can be the person who somebody can maybe come to in that moment. Maybe. We don't know that. I don't feel like that's a given either. So all of this is a question of timing in some ways, and luck and non-luck.
Mhm.
So in my situation, my dad in recent months had expressed, I was lucky, he called up and said, I don't want to live anymore and I'm thinking about ending it. That was a very different conversation than, a follow-up conversation where it didn't happen. And that's a tough conversation. And somebody asked me, well, what did you say? And I was like, well, first of all, I didn't shy away from the subject, right? Once the door was open, I'm like, so how are you thinking about doing it? And have you thought about what happens to the people that you're leaving behind and your legacy and all of those things? In this moment, have you thought about what you leave behind? And then I even got a little more nitty gritty with them. Like, when are you most thinking about not living? 3 a.m. And I'm like, okay, 3 a.m. Great to know. Will you call me at 3 a.m. for the next few weeks? Why? What will you do? And I'm like, nothing, but I'll be on the phone with you. Just knowing that moment, it wasn't that I was going to have magic words for him at that moment, but he wasn't going to be alone with it. And that was something as a family member I could do. I couldn't do much else, but I could do that. And I can say within, 10 days of that, we had to come up with a slightly different plan, but at least the conversation was open and we were looking at it as an acute issue that needed to have medical attention.
Right. And there's so much that we know too that, conversations don't always have to be about exactly what's going on for someone, right? Certainly good to know that the door is open and that, folks when they're struggling can often want to know, is the person I'm talking to able to handle this? Or are they going to run out of the room with their hair on fire? And that somebody's willing to lean in and have that conversation and ask that next detailed question, like, when are these thoughts showing up for you anyway? Shows that you're there and you can handle it and be there with them. And I love that idea too, and the data bears it out as well, that the conversations when somebody's really struggling at 3 a.m. or whenever it happens to be, doesn't have to be about the thing they're struggling with. It can be a conversation about almost anything, because really what we're trying to do is help somebody navigate that toughest period of time for them. And if all we do is sort of move past that time and distract and think about something else, we're helping someone to move out of that suicidal crisis. We're helping them to get past that most difficult time. Because at least in the case that you're saying with your dad, the rest of the day wasn't so bad. It was really getting past this rough part. And that's where they needed support. And you had to lean in and ask to know all that.
Right.
Yeah.
Absolutely.
I wonder too, I know one of the points that you talked about, Margaret, before was this idea of giving family members and especially kids shock absorbers. That sort of early on when we're having these conversations, before there's a crisis, before something's gone on, that there's more that we can do to help people be ready for these situations. And I think it's such a great model, and I'm wondering if you can speak to it more, this idea of shock absorbers generally for kids.
Yeah, and what we learned was, and this is kind of a prelude to that, is that suicide, whether we like it or not, is part of the nomenclature of younger kids, young as 8, 9, 10, 11. And so there's this, I think, for us at our age, it's like, well, you didn't talk about that when you were that age. But really, you have to start talking to kids at an early age about how do they feel, what's bothering them. That the shock absorber is about letting them know that what's going on in this moment is not going to destroy you, is not the worst thing you're going to experience, that you can get through it, that nobody's going to judge you, that things will be better. And I think for Victor, our son, having gone through his phone, there was no conversation about suicide, but we did talk to him about this, and he made it clear that kids talk about it all the time, but nobody talks about it outside of their underworld, their fake Instagram accounts, their social media accounts. And so we talked about it and talked about self-harm and girls who cut. And I think teaching children, really children, as much as parents may find this distasteful, at a young age to talk about sometimes you get so mad and what do those bad feelings feel like? And that space that you speak of is so true, because it is a minuscule space that you're in when you're in that point of trauma. And to Diana's point of saying, well, let's talk about it, or let's find that time that we can talk when you're at your most distressed, and deflecting it a little bit gives us measure of hope, I believe, to the person who's suffering, that they actually got through that moment. And I think that you have to allow children and young adults to express what they're feeling, even if it scares the pants off of you, because you can't help them if you don't know what they're saying. I don't know if it was you, Jonathan, or Diana, who said, emotions are information, which I thought was just a brilliant statement. I mean, it's so true.
It wasn't me.
But, you know, you have a kid, maybe even a 3 or 4-year-old or 5-year-old whose parents are scared about COVID, who's maybe saw their grandparent die, or a kid get bullied at school. They have to learn how to express that and not take it out on themselves by eating or cutting or pulling their hair out. And, you know, we never saw this coming in a million years. But we also know that a 21-year-old brain, a boy's brain, is not fully developed. And so emotionally, if you add in, unfortunately, drugs and alcohol that he normally didn't do, and you have the impulsivity, which is what suicide largely is an impulsive act, as Jonathan said, predicting it, you know, clinically is next to impossible. You know, you have no control over what's going to happen next unless you're standing right there and you can literally dive on the person, which is normally never going to happen. But I think to your point, Jonathan, it is that, how do we get people out of that space? And I think the way that we begin to help people, children, adults, is we have to talk about it. As simple as saying, hey, does anybody at school ever talking about harming themselves? You know, did you hear about so-and-so in school who maybe the parents know took their life or tried to get rid of the taboo? You have to talk about it. You have to, because it's not, there's no pill, there's no blood test, there's not going to be. The only thing we can do is to begin a dialogue, an active, consistent dialogue that they're going to hear. They may not like, but they'll hear it.
Mm-hmm. Absolutely. Absolutely. I think, right, acknowledging that you know, kids and young adults are hearing about these phenomena. Self-harm is one that shows up often, right? We see them as being very close to each other, self-harm and suicide. Their relationship is a little more complex in the data, but it's often part of the same conversation in families. And kids do hear about that, all forms of self-harm, from burning and cutting and things to that end. And it's important for parents to acknowledge, you know, if it's sort of known that someone in school might be doing this and your child may be hearing about it, it's good to ask, what do you think about that? Have you had thoughts like that? Knowing that you as a parent are someplace where that conversation can take place and there's not shame and taboo and fear about it. I know also we talked about this idea that parents often have an understanding as their kids are growing up, right? Every kid is different. They have different strengths and weaknesses. They have things they're better at handling and less good at handling. And parents will often know if maybe one child is more sensitive than another or struggles to manage emotions better or worse than another. that's great information to have, because so much of what's useful there is, rather than that child sort of moving along in life and getting to a place that's harder and not being prepared for it. We talked about sort of, if we could wave a magic wand and change the way the mental health care world works, we would move away from this idea that kids and adults and everyone in between only goes to see somebody in the mental health space when they're very mentally ill. And instead we had something that looked more like a checkup model, something, similar to what happens with the primary care doc, where you have a relationship with somebody already that gets to know you as you're growing up, once a year, 6 months, something like that. And so that when you do run into a crisis, when, say, there is a breakup at school and it really, grabs you and spins you and you feel like the world is going to be terrible forever, there's already somebody there that's a professional in your life that you could go and talk to, and who's going to be able to understand you and help translate what you're feeling, communicate it to your parents. All of those things could be helpful. And beyond that, that idea that, parents can help their kids to some degree understand that emotions are information, which means there's no bad emotions, there's no good emotions. The worst thing we can do is not feel whatever we're feeling. And so this is where I'm going to quote Diana, right? Any feeling fully felt passes. Did I get it quite right?
Every feeling fully felt.
Every feeling. Right. Which is it's a great message to teach kids. It's sort of, no matter how bad the thing is you're feeling, no matter how intense it is on the inside, if you don't try to bury it or get rid of it or deal with it with drinking or drugs or cutting or pulling your hair or taking it out on someone else, if you actually feel that feeling, it will go away. It will resolve in time. And I think that can be as novel a phenomenon to the budding therapist as it is to a parent, as it is to a kid. That's not really the language that we're surrounded by in the world. That's not usually what we're taught. We're taught ways to sort of get by things and get past things and work around them. So that seemed like a really important message as we were talking, to make sure that it's part of that conversation, that there's space for all these things.
Okay.
Mm-hmm. Mm-hmm.
I wanted to say too, before we move on to sort of the next phenomenon we want to discuss, what other things do you all think are really important for families to know sort of right now, whether they're in a position where they have a loved one that's struggling with mental health and suicide more broadly, or they're sort of earlier on in the process and they want to see what they can do to intervene early on? What else might you want them to know?
Diana, you want to go first?
Sure. Well, that despite the fact that friends can be there for lots of things, very often friends aren't the go-to in this scenario. They don't know how to speak about it, and very often it may be too scary. So to seek a professional who hears the word suicide or taking life or any of those expressions and doesn't gasp is going to be infinitely more reassuring than talking to that person who is just dying to hang up the phone so they can ask their kid, "Are you safe?"
Yeah, I think you have to remember, particularly for kids, sometimes they'll triangulate, so they won't tell you, but they'll tell someone else, and it might even be another parent. And my message to those parents is, you need to let the parents know what's going on, not freak the kid out by saying, "Oh gosh, you shouldn't think that way," but to stop the triangulation, because the child obviously, or the person obviously, wants help. But they may be so frightened by their perceived notion of how you'll react that they won't come to you. And I think you have to reach out to the parents and make sure that the child is being heard at every level.
Mm-hmm.
At every level.
Right. I'll add to that too, that idea in here that there's a space where the child can come and talk, right? Whether it's probably not a friend, it probably will be somebody that's either in a professional role or a family member. This idea of not overreacting, the idea of being able to listen and hear what's going on. A mentor of mine, Barry Walsh, who's a self-harm researcher, talked about the importance of a dispassionate curiosity. And what he means by dispassionate is not cold, but just this idea that it's not full of energy, that, "Oh, well, what were you thinking and what's going to happen and you're not going to do this, are you?" But this idea, similar, Diana, to what you were talking about, where I'm asking the next follow-up question. When do you have these thoughts? Where do they come from? What do they like? What language do you use to think about it? Do you think about just falling asleep and not waking up? Are there things you're planning to do? That sort of approach is what can be most beneficial, which, by the way, I think as we were discussing it too, that's a huge ask for parents and family members to not have a lot of emotion, which is, largely where our thinking around having professionals involved is helpful, because professionals have that extra layer of distance. They can have that dispassionate curiosity to ask those questions and not think, oh my God, my child is having these thoughts. What on earth can I do to prevent it from happening?
Yeah.
So the distance, I guess, is important there to some degree. I know too, something that we all talked about and that certainly is not discussed nearly enough is how can we as a field, as a community, as a people, be supportive to families that have suffered a loss or families that are struggling in this way. And I think for the large part, there is almost zero literature to this end. There's almost zero research to this end. And I don't think there's nearly enough clinical work done to this end. And it's massively important because as we go through life, we will encounter people close to us who have dealt with a loss like this and who can benefit from support. So I guess, Margaret, to start with you, what, so far as you can tell, do families need after a loss like this? And how can friends and family and those around be supportive?
I think when it first happens to the family, when you literally find out and can process what has happened, you're in such a state of shock that you need a support system that's just going to be there. You don't have to do anything, because what we have told people who, we had a very lonely journey. Aside from our immediate family and some friends, most people stayed away, and that's tough. So I would tell anyone that if you know someone who's gone through this, there's nothing you can say, and there's nothing that they can say to you, but just to say, I'm sorry, I'm here for you. Because it is something unlike any other loss that you can't fully process. Today, it was 2 years this past week for us, and I'll never be able to process the how and the why. But in that moment, you need people who are reassuring you that the ground isn't going to fall out from underneath you, that you can breathe, that you're going to live, that this isn't the end of the world, and to simply just be there and hold their hand and don't ask questions, because it's just, you don't even remember the first 6 months. You don't. So you just need to know that someone is there that cares about you, that isn't judging you, that, just wants to be there. If there are children, other children in the family, Victor was our only child, but we know from going to group, families need to get help right away. They can't navigate this alone. And it's very difficult for the fathers or the men, because men are not necessarily willing to be vulnerable in their grief. And Neil will talk to men and say, you have to come, you have to cry, you have to let it out. But getting help is the number one thing I would tell people who are going through this, because you can't go through it alone. You need to find support. You need to be with people who understand what you're going through and can hear the things that you need to express that are unlike any other grieving process. The things you talk about with respect to a suicide and what you went through and what you had to see or witness or deal with is not common to any other type of death, in the way that I couldn't understand somebody who had a loved one who was murdered. It's out of the realm of comprehension. So, and there's no shame in asking for help. You have to, because your loved one, I'll bet you $1 million, would never want you ever to be in the pain you're going to be in. That's not the intent of the suicide. If you read enough about people who survived it, people who think about it, they're not thinking about hurting anyone. They just either want to get out of pain or want to reduce the burden they feel they've become to you. So the best thing you can do is take care of yourself. It's never going to be the same, but you can move forward and breathe.
Right.
Right.
I know two of the sort of big picture phenomena there too that are so important. When we think about how folks come to die by suicide and what the literature does largely understand, there's two terms you talked about there that I think are so important for everybody to understand. And one of the oldest theories is this idea of psych ache, right? Just that the person struggling is in so much physical pain, they'll do almost anything to be rid of it. And that's where they turn to something like suicide, right? Nothing else has worked. I will turn to this. And the other is this, Thomas Joyner, who's probably the leading theorist on suicide, has three major components that go into what it takes for someone to die by suicide. But one of those components is that perceived burdensomeness, that there's something about me that is a burden on the people around me. And so that's something that moves me closer to dying by suicide. And so in that, totally agree. Someone who's struggling and in that much pain and thinks they're actually going to relieve the folks around them of the burden they're in does not want to cause pain in what they're doing. Can't possibly see that what they're going to do is going to cause that kind of pain. It is an act to relieve their own pain and hopefully relieve the pain of those around them. But when someone's in that state, they're not capable of conceiving the kinds of damage that they would do to a family around them.
I think, Jonathan, to that point, if I might add,
Please.
as you said earlier, the space that they're in is wafer thin. And so when they're in that moment, which is why none of us sitting here today can comprehend it because we are not in that frame of mind. But when they are in that moment, all they're thinking of is leaving and their pain. And whether it's rational, whether it's drug fueled, alcohol fueled, anger, mental illness, there are 500-foot steel walls around that space. They're not thinking about anything but that moment, because I, to my last breath, know that Victor would never have caused this harm, especially to his father. Never. And that's a hard thing for the outside world to understand. They'll think, oh, well, that was really selfish. Well, on a clinical level, yeah, I guess it was selfish because I needed to relieve myself. And it's a pure self-interest move, in part to save other people from going through more agony because they think they're a burden.
Worthless.
Right.
And then you have, for the people who do actually survive a suicide attempt or close to an attempt, the processing with family and those other people who are important to them. How could you have even thought about leaving me? Did you realize what it would do to us? And having those conversations with somebody to be able to process the anger that, even though you're incredibly grateful that the suicide was not the vehicle for which their life ended, you are still, as family members, very, very confused and ambivalent, and it's complicated and messy. So to get that support where you can continue to talk about it, because the most harmful thing to the family then is post-attempt to stuff that back in that elephant box, right? We're not going to talk about it. That's over. Never happened again, never will. And I think that's the most damaging, because the person who has been in despair feels isolated in their despair, and everybody else feels isolated with them.
Mm-hmm.
Right.
Mm-hmm.
And so it's a spot where we're saying, after an attempt has been made, whether someone has died by suicide or there's been an attempt that's been thwarted or aborted or interrupted, there needs to be some conversations, right? Whether it's going and getting help, Margaret, like you said, that this is not something that families can get through alone. Similar to Diana, to what you were talking about before, friends are great and are helpful, but there is a need to be with people who understand this perspective and understand this point of view and have some understanding of the loss that's going on. But also this idea that if someone has attempted suicide and they're still here, they've survived it, there's so much conversation to be had with the family there. And part of that can be a complicated, messy process where some families can't understand, like you've talked about, Margaret, that there's this wafer thin area that someone's mind goes to that other people can't understand. And so family members could think about things as being selfish, or why would you leave? To families reacting in different ways, and people within a family reacting at different paces. If there is a grieving process to go through, I know this is one of the challenges, Diana, in thinking about whatever a quote normal grieving process looks like, and a grieving process after someone's died by suicide. There are differences between those, it sounds like.
Absolutely. I mean, I think the standard, what is it, anger, denial, bargaining, all of
Acceptance, yeah.
acceptance, that was originally written for people who were actually dying, not for the rest of us in dealing with it. But I think that the sense of shame, and I think there is a sense of shame that family members feel that they could not somehow create a life or answer that despair. There is a shame in that. And even with the shame for their loved one, because other people might be judging them. So there is this confused stew of shame that goes on with people.
Yeah, I mean, the hard part is we were out walking the dogs about a month after, and I said, do you think people are looking at us thinking, what went on in that house? What happened? Why didn't they know? And my husband's like, it doesn't matter what anybody thinks. And it doesn't. But you sit there, and I can sit on this panel and hear everything I'm saying, and then hear somebody say, well, then why weren't you able to prevent it from happening? And I don't have an answer for that, because we never saw it coming. But there is a tremendous amount of shame and embarrassment that this happened to you and your family. And there's like, well, why? And someone said something like that to me, and I go, if I ever figure out the why, I will put it on the front page of the New York Times.
Right.
Shame is huge.
Shame is huge.
Right. And it's challenging too, I'd say, certainly for families to figure that out. And then on the flip side, for clinicians, if you've lost someone to suicide, I mean, here you are in this, if it's expected that families should understand it. And somehow there's this understanding from the populace in the large, wow, what was going on in that household? What didn't they understand? I think important to keep in mind that, the state of the science, right? The state of clinical work as it stands cannot know these things, with millions and millions, or probably billions at this point of dollars spent, down to the clinician that meets with somebody weekly or multiple times a week, or someone in intensive outpatient, or someone in a residential treatment center, where we theoretically have people on suicide watch 24 hours a day, 7 days a week. There are still people that die by suicide. So it is one of these phenomena where I'm not prepared to say, there's nothing we can do to reduce the likelihood that someone would die by suicide. Not true. I mean, that's part of what we're hoping to discuss today, and what we've talked about, ways we can help families have this conversation, open the door, prepare people so that they're a little more resilient when challenges of life show up. There are ways to help. But there's a difference between that and saying that anybody can stop an individual from dying by suicide, or knowing who is going to. And we can't. We cannot. And we're largely probably preaching to the choir on this talk, and still seems incredibly important to say.
I think to that point, you can do everything. You can have the best of intentions. You can have the best home life, but you don't know what's going on inside someone's head. And it doesn't matter how old you are. People hide what they want to hide. And if they don't feel safe, and that may just be in their own mind, they're not going to say it. You can't stop it. I mean, my husband saw him 4 minutes before he did this, and he was right upstairs and sent him a text, and that was it. What could you do? And you'll go through it a million, for anybody who's experienced it or has lived through it or knows somebody, you will go through it 400 million times ad infinitum until you get to a place where you realize it happened. And the hard part about suicide that we really need to let the population out there know is that the more we talk about it, the more we let people know how it impacts families, what it means, that it is a permanent solution to a temporary problem. You can't come back from it. There's no, I'll show them and then I'll come back tomorrow and see what everybody thinks. We have to talk about it. We must. And there's nothing to be afraid of. It's just a conversation. And you'll be glad you did, but you can't stop it unless you start the dialogue.
That's right. That's right.
I know one of the things I'll often do in clinical practice when somebody shows up saying they're considering or thinking about suicide, that it's on their radar at all. We don't take suicide off the table as an option. It is an option. It's something that someone can choose to do, but we do highlight exactly that point, that this is a permanent solution to a temporary problem. And that's probably not a good starting point. Let's go through and look at all of the other things that are going on there. Because for some folks, having that idea of suicide on the table, right, that I could escape from the really difficult things that I'm feeling is important. They need to know that that is there for them, and it is. And can we work together and figure out what are all the other ways you can cope with these things first? What are the conversations you can have? Who are the people you can meet with? What are the activities you can engage in? All of those things are totally available to you. And I don't think the ask is ever that we would want families to try and articulate that kind of conversation. That's a big ask. But I do think there is real value in highlighting that it is that permanent solution to a temporary problem. And I think it is really helpful for families when they're having some of these conversations in advance to say, what else is there? What else do we have? How else can we generally deal with our emotions? Yeah. It's hugely important.
So I have a question for you, John. And that would be suicide hotlines, all of those. Is that a resource that if you have somebody who's talking to you about taking their own life at that moment, dying by suicide. Yeah, it is an old practice. This is going to take me a little while. Dying by suicide. Do you arm them? Do you give them those kinds of resources? Because if we're talking about a wafer thin moment, and you're not available, I'm not available, Margaret's not available, Mom's not available, they need to have that available. Yes. Is that something you advocate for? Because we know those hotlines can be life-saving for some people.
So it goes on the list for me. If I'm working with a client and I have a number of people in my practice right now that I consider to be higher than low risk, and some of them are high risk to die by suicide, relatively speaking, on an outpatient basis. We have a safety plan that we go through every session. The session is the safety plan. And on that list is things, your warning signs that you're not doing well, things you can do on your own, and it goes in this progression, things you can do on your own to help alleviate what's going on. People you can be in touch with that you just want to shoot the breeze with, that doesn't have to be about what's going on. People you can be in touch with that are professionals. And then one of the last sections there before you get to restricting means is, what are sort of the emergency contacts, right? So I would be on there, the psychiatrist would be on there, after hours numbers would be on there, a coach, a case manager, and suicide hotline, National Suicide Crisis Line is absolutely on there, and the number for their local ER and the address for their local ER. I mean, we know that folks, when they get in this space, it's very narrow thinking. And so we want this to be as prescriptive as can be so they can just follow along and go down. So hugely important are those particular resources, but they're one of many things. It's not the single thing I would rely on in practice.
One thing, I just wanted to bring one thing up when saying all of that. The one thing I would tell family members, parents as well, particularly of younger kids, is during COVID and the isolation, kids tend to, on a normal basis, be isolating in social media, but even more so now. And that is always a very combative conversation with your kid, like, let me see your social media. But the one thing that I did learn, I had to read his phone. And the one thing I did learn was that younger people have a way of talking to each other that is not very kind. And that they say things online and they say things on text, because I was obviously never supposed to see those texts, that had nothing to do with suicide, but were so outrageously disrespectful and crude, and it's a normal dialogue. And what I would say to parents is talk to your kids about being kind. They may be the kindest kids in the world, but they may not be kind to each other. And because what comes out of your mouth has impact. And ultimately that was the trigger for Victor. And I think that we have to teach our children in this conversation that what we say, that words really do have an impact. And we need to be kind. And we need to see, if we see someone struggling, not make fun of them, not give them a hard time, reach out. That the kindness we share, particularly during COVID, and how we treat one another is as powerful as sitting with a therapist, because it validates your worth as a person. And I just had to express that before the end of this.
Absolutely true. Absolutely. I know too, we wanted to leave a little time at the end for questions that had come in. And I think Whitney, who kindly introduced us, was going to moderate that and sort of pass those along. So Whitney, I know you've been keeping track of those questions. What's been coming our way?
Great. We've got a lot of great questions and we'll do our best to get to them all. If we can't, we're going to leave our contact details in the chat box, and please feel free to reach out to us if we're unable to get to those questions. We had a lot of fantastic questions. One question is, there's a lot of fear that having this conversation with a loved one might plant a seed in their head or might make suicide a more viable option. Can you speak to that a little bit? Is that true?
Not in my experience. No.
Yeah, no, completely untrue, and the data support it.
Yeah.
Asking about suicide does not increase the likelihood that somebody will attempt suicide or think about it more often or anything like that. The only thing the data shows that asking about it means you're more likely to hear about it and therefore more likely to reduce it from happening. So it actually has the opposite effect.
Thank you. And one question we received is, how do you handle it if your child is telling you that their friends are talking about harming themselves? It's, very hard to tell another parent that their child is saying these things. I think there's been experiences where another parent might share something about their child and they get angry or just don't want to hear it. What's the best way to handle a situation like that?
So in my experience, because I did navigate almost teenage years and was privy to some of that information, one of the tools, if I did not have a relationship with the parent or I did not think that a fellow parent was going to be receptive, I called the guidance counselor at the school and advised the school that this was an ongoing conversation so that they could at least look at that in a professional level.
Now, Diane is much nicer than I am because I would be very nice and diplomatic and I couldn't care less if they got mad at me, and this is hindsight now and experience, but I would, in the kindest possible way, say, this is what's been expressed. And I would also tell the guidance counselor as well. I would cover both bases, but
and you're actually nicer than I am. You're braver.
Yeah, I would definitely. The hard part is, and when we're talking about all of this, we're assuming that everybody's living in a highly functional house and that they have loving parents and siblings and everything's perfect and nice. And it could be, that's what our house is and was. But there are people who are living in horrible situations, who feel unloved, who are going through a divorce or something. And it may be hard for them to hear, but at least you've done the right thing. And if you have to go to a child advocate or someone else, or a priest or someone, you do what you have to do.
Yeah. Yeah. I think you have to do what you can be okay with. And the specific person to talk to or a set of people, I don't think there's a wrong way to do it among the way that we've discussed it. I think the only thing you really can't or shouldn't do or probably wouldn't be okay with is saying nothing.
Nothing.
I think that fits with the overall theme of the talk is if there's basic components in our ancient brain that say approach or avoid, a lot of research on that, organisms either approach or avoid a thing. We are naturally taught to avoid suicide, whether we want to or not, discussing it, anything like that. And I think the overall theme has been with all of these things, from having discussions early on, or when someone's in crisis, or when a family is dealing with something after the fact, or when we hear about a child that's struggling, the move is to approach, is to move towards it.
Mm-hmm. Fantastic. We got another great question. What's an appropriate way to talk to very young children about suicide? For example, what do I say to my 6-year-old whose friend's father died by suicide recently?
Good question.
That's a great question. It would so depend in part on the relationship the child had with the person who died. Did they know them? Was this just information that filtered? And I think to keep the explanation age appropriate would be, we don't know why this happens. We know that we take all the steps possible in our families to make sure it doesn't happen. But I don't know what I would say to a 6-year-old at this point. John.
Yeah. I don't know that I have a perfect answer, but I think a lot of my conversation would be around emotions and feeling intense emotions, and how there are times when people feel like those emotions are so strong that they can't handle them anymore. And while that's what happened with this person, I think the conversation would be about, so here's what we can do with intense emotions. Here are the other ways that we can handle them going forward. Not to say that there's anything bad or wrong with this person, but hopefully we can have things be different going forward with the people we know and with ourselves.
Great. And then we have one final question. What can clinicians do to really support and help clients that might be at risk? And also, how can they, protect their own professional liability? I think there's a lot of fear about working with patients where there is a risk for suicide.
Absolutely. So I would say working with patients that are at risk, similar to the phenomena we've talked about here, having the conversation, being open, being willing to hear about plans or attempts or things to that end, having that be a space to operate. I can't advocate strongly enough for learning how to do a great safety plan or crisis response plan. There's data that show that those actually work. Don't contract for safety. It doesn't work. You're actually wasting your time, and you could be doing other better things with patients. Learning how to do great safety planning is free. You can find it online. Stanley and Brown are the two authors of it. There's trainings available by video and whatnot, and that becomes the session. In terms of liability, so long as you are asking about suicide and you're recording what someone is saying and you're doing your due diligence to pay attention and write down what's said and trying to mitigate risk, I think you're doing all that you possibly can for that person. So, and I'd say last, when I'm putting together my note, and this is what I've taught interns and residents to do, is your safety plan is your note, more or less, when you're documenting it. And below that is a really nice detailed account of what are the chronic risk factors for this person, demographics, past diagnoses, past attempts, and what are the acute risk factors? What are the today things that are bringing them to be at higher risk? If you're doing all of that clearly and you're doing your due diligence as a clinician and consulting with other colleagues, you're always going to be doing more benefit than harm to your patient.
Fantastic. And this concludes our panel for the day. Thank you again to our amazing panelists for sharing their expertise and personal experiences. And thank you all for participating in this really important conversation. Please feel free to reach out to O'Connor Professional Group if there's any follow-up questions or comments. We'd love to hear from you. Thank you again and have a great rest of the day.
Thank you.
Thank you.